I'm Jenessa Thirion. I'm one of the nurse practitioners for the Pediatric Pain Service, and I'm going to be presenting the do's and don'ts of opioid prescribing. The objectives will be to review the opioid epidemic, discuss the recent implementation of legislation for opioid prescribing, discussing the ORs, and discussing opioid pharmacology, and then also just family and patient education related to opioids. So some definitions to review are going to be: tolerance is when patients have been on an opioid, for example, for a prolonged period of time, and because of that exposure have increased their tolerance, meaning that they're going to need more medication to get the same effect that they were getting in relation to pain control. Dependence is when you've been on an opioid and sometimes a benzodiazepine for 7 days, 5 to 7 days. The body can become physiologically dependent to that medication. So if you take that medication away when they've developed that dependence, they're then going to show withdrawal. Withdrawal usually occurs after about 7 days of being on consistent scheduled pain medications. And again, it can also be benzodiazepines. And in that, they show clinical symptoms. With opioids, that would include GI symptoms, so nausea, vomiting, and diarrhea. With benzos, it's going to show more of the agitation, tremors, and those types of symptoms. Addiction may have all of the three. They may have tolerance, dependence, and withdrawal may be a part of addiction, but true addiction is when a patient goes out and is looking for drugs and they have a craving for a drug, and there's a psychological dependence to this. So they knowingly will go out and sell their things so that they can get medication, so they can get money to go out and buy some medication or whatever drug that their drug of choice for their addiction. So it's a psychological dependence, and just because a patient has tolerance, dependence, or withdrawal does not mean that they are truly addicted to a medication or a drug. So the United States opioid epidemic, as we've probably all heard. So what does this epidemic look like? The national survey suggests that almost 2 million people start opioid pain relievers annually. In 2012, healthcare providers wrote for 259 million opioid prescriptions. In 2014, greater than 10 million people reported using opioids non-medically. I also found somewhere else where it had stated that in around 2014 that there were enough opioids that were prescribed that every adult American person, so an adult American, could have their own bottle of opioid prescriptions. So with prescribing, around 11% of high school seniors have been reported a history of non-medical use of opioids. Healthcare providers often prescribe more opioids than the patients routinely need at discharge. We're seeing this more with dental-related procedures, but I think it's something that we're all trying to keep in mind when we're writing for opioids. And it's also been shown that it's only been 4% effective when patients and families are informed how to dispose of medications and they actually go and do that. So it's not occurring very often. This map shows the opioid deaths throughout the United States in 2015, and you can see that Ohio is in red, so it does definitely have a higher rate of opioid-related deaths back in 2015. This is another slide that also shows the opioid epidemic in the United States in 2015, and you can see from this that there have been multiple prescriptions that have been prescribed, multiple patients who are passing away from the opioid epidemic, and then also just the amount of money that is being spent on this opioid epidemic. In 2017, the White House declared that there was an opioid epidemic nationally and that it was a public health emergency. So now to go more focused, looking at the Ohio opioid epidemic. In Ohio, it's been shown that there have been over 3,000 overdose deaths in 2015. And 85% of those included opioids, and 38% were from fentanyl. This chart also shows how much of the number of opioids that have been dispensed in Ohio by year. So if you notice in 2011 to 2012, there was definitely an increase in the number of opioids that were prescribed. And then incrementally, yearly after that, it has decreased. So we have definitely decreased the number of opioids that are being prescribed in Ohio. And this is also just another that is showing you how many opioids are being dispensed and written for patients. And again, we're definitely decreasing the number of opioids that we're prescribing to patients. So this slide also just shows unintentional drug overdose deaths. And if you notice in 2011, it says 40.9%, and it goes down yearly to 2017, where it's 10.8% of deaths that are related to drug overdoses. So this chart shows the number of fentanyl and related drug deaths that are unintentional from overdoses. The green is the fentanyl, and the blue is the prescription medications. So you're noticing there's a decrease again in those prescriptions. And then this chart also just shows, and it goes by year. So if you look, there's coloring for each year, and it goes over the prescription opioids, which are definitely trending down. Fentanyl and related drugs are trending up. Heroin was down, then it came up, and it's starting to come down again. Benzodiazepines has a little bit of fluctuation, but it's about the same. Cocaine is starting to trend upward, and psychosomatics are also starting to trend upward, just looking at those broken down by class. So the Ohio Governor's Cabinet Opioid Action Team. The Governor's Cabinet Opioid Action Team was established in 2011 with the goal of fighting opioid abuse. And with this cabinet, it consisted of healthcare providers, law enforcement, addiction and treatment professionals, educators, parents, and many others. And this shows you the timeline of what the opioid task force has done. They started off with, you can see Project Dawn is on there, so that's making it so that Narcan is available to patients. You can go to any pharmacy without a prescription and can get Narcan. Ambulance and EMS first rescue teams also have Narcan available to them when they go to different scenes. The ORS was developed, and there was the Start Talking, which is more so focused on on adolescents and families, and what signs can you look for if your adolescent is abusing a medication. There's actually videos on there that I checked out when I was looking into this talk at the beginning, who talk about what happened to their child who actually passed away from an overdose, and what symptoms they had seen and wish they had noticed sooner to try and make it so they could have prevented that overdose. So all that information is on there, and it's a good resource for adolescents and parents and ways to talk about that. And then more recently, the Ohio came out with their opioid prescribing legislation, which we will go over next. So the Ohio opioid legislation went into effect December 29th of 2017. The key points to that are that you need to first consider non-opioid treatment options. So can you use other things other than an opioid to treat the pain that this patient is having? Those could include Tylenol, an NSAID, lidocaines, patches, those things, so that you aren't having to use an opioid, or even using non-pharmacological management. So meditation, hypnosis, massage, acupuncture, just thinking about those different options before you are prescribing an opioid. If you do feel that prescribing an opioid is the appropriate thing, then making sure that you are giving the lowest number quantity, and what they say is, if you can, keep it to 3 days or less, and then potency. So making sure that you're giving, for example, oxycodone, you're giving 5 milligrams as opposed to a 10 milligram tablet. So just giving those smaller doses. You also need to limit all of your opioid prescriptions of acute pain of minors to 5 days and adults is 7 days. It prohibits prescribing extended release opioids for acute pain. It requires patients to be advised of the benefits and risks of opioids. And it limits the total morphine equivalent doses of an opioid to an average of 30 MEDs per day. So with the opioid prescription limit, it does say that you should prescribe opioids for 5 days or less for a minor. That doesn't mean that if you have a patient that, let's say, has had a big surgery, so a big orthopedic surgery or a pectus repair, which can be very painful and take time to recover from, if you feel that it is appropriate to prescribe them for more than 5 days and, let's say, prescribe them for 7 days, by no means does this legislation tell you you cannot. It just states that you need to document that you are prescribing for 6 or 7 days, whatever amount that's over 5 days, and why you deem that appropriate. If you do prescribe for more than the recommended amount, so 5 days for minors, then you are subject to additional review by the medical or nursing board. So the differences between immediate and long-acting opioids: immediate is going to act quickly, so it works within 30 minutes typically. It's going to last for 4 to 6 hours. You use the immediate release opioids for acute pain in short periods of time. You can also use it for breakthrough pain if you are using long-acting opioids. And then long-acting opioids are typically given BID. It takes a while for that to completely disperse within your body. And then it's commonly prescribed for patients with cancer pain, and that's really the only ones that it's really prescribed for now that I know of. So prescribing opioids to minors, in 2014, they came out with the Start Talking consent form, which is required when prescribing a controlled medication to any minor. The consent requires 3 components: so assessing the minor's mental health and if they have any substance abuse history. So you also want to discuss the risks and dangers associated with taking a controlled substance, and then you also need to obtain a signature from a parent or guardian from this. It's strongly encouraged, although is not mandated, that you send in a copy of this consent form when you are writing for a prescription, or writing on the prescription that you have obtained this consent when writing for a prescription. So exemptions from this are going to be anyone that's in the emergency room for a medical emergency, is associated with surgery, if their care was rendered in a hospital, an emergency facility, a surgical facility, or a respite care facility. If you fall into any of those, you do not have to do a consent form, but the consent forms do need to be completed if you are prescribing opioids on an outpatient basis. And this is just a picture of what the Start Talking form looks like. If you don't already have this, you can easily find it. If you go and do a Google search, you can find the Start Talking consent form pretty easily. So morphine equivalent doses, what does 30 MEDs really calculate out to be? So if you write for oxycodone 5 milligrams PO every 6 hours, that is going to be equal to 30 morphine equivalent doses. Vicodin is going to be 7.5 PO-Q6, and Dilaudid is going to be 7.5 milligrams per day. So if you write for oxycodone that's greater than 5 milligrams PO-Q6, like I will write for 5 milligrams to 10 milligrams PO every 4 to 6 hours. So I'm potentially writing for more than 30 morphine equivalent doses. You then just need to make sure that you write something in your notes stating that you are writing for more than 30 morphine equivalent doses because the patient is post-surgical or whatever that reason may be. So who is exempt from these opioid limits? Hospice patients, if you're a palliative care patient, terminal condition, cancer patients, if they are getting these prescriptions for detox, or if it's just an inpatient prescription. So prescribing long-term pain or subacute pain is a newer legislation that went through, and it went into effect December 23rd of 2018. So how they define this is long-term pain lasts 12 weeks or more, and subacute pain lasts between 6 to 12 weeks. So with this, what this legislation is saying is that if you prescribe for 15 morphine equivalent doses, then you are required to evaluate the patient and their underlying condition. You need to assess their function, look for signs of any misuse, and consider consulting a specialist and obtain a written informed consent. 80 morphine equivalent doses, you need to do all of that for the 50, and then you need to consult with a specialist, and you need to have an agreement, and you need to also consider a Narcan prescription. And for anyone that's prescribing for over 120 morphine equivalent doses, then you need to, it's recommended that they go see a board-certified pain medicine physician or a board-certified hospice or palliative care physician and have a real face-to-face visit and examination. So who does this not apply to? It's similar to the other ones. Patients with a terminal condition, patients who are in the hospital or inpatient settings, and anyone who already had these doses prior to when this legislation went into effect, which was December 23rd of 2018. So with prescriptions, what you need to have on an opioid prescription is you need to have the number of days of your supply. So it can't say anymore that you are dispensing 10 pills. You actually need to say dispensed amount for 3 days. You also need to have the ICD-10 code on there. I will put the ICD-10 code, and then sometimes I will put their diagnosis. So for me, typically it's post-surgical patients, so status post a posterior spinal fusion, just so that I have both of those there. It's highly encouraged if they are exempt from the opioid consent form that you are writing that, or that you have the consent, so either one of those. And just a reminder that you are exempt from an opioid consent if it's associated with surgery, if it's treatment that was rendered in the hospital, or if you're prescribing this at the time of discharge. This is an example of what our EMR for the inpatients when writing a prescription looks like, and you can go in and put a pharmacy memo, which is what I tend to do, and I type in what the ICD-10 and what the number of dispensed amount is. You can also go and find the ICD-10 by searching as well through our EMR. And then this is what the prescriptions look like of where the ICD-10 is and the dispensed quantity amount. So those are the areas that people are going to be looking. So ORS, everyone should be aware of what ORS is, but it's Ohio Automated Prescription Reporting System. It was established in 2006, and what it is a web-based system that you can look and see all outpatient prescriptions of controlled substances that are dispensed and prescribed for within Ohio. So when should the ORS be used? It should be used prior to any initial prescriptions, every 90 days, at any point that you feel that there is a red flag. The best practice is just to run an ORS report at every office visit. And then they have added gabapentin and Lyrica to the ORS profile, which when I first heard this, I thought was interesting. But gabapentin can actually enhance the euphoric effect caused by opioids. A fifth of those who abuse opioids misuse gabapentin. So gabapentin has euphoric effect when used alone, similar to that of a marijuana high. So you can also abuse gabapentin on its own. So red flags could be someone who is consistently asking for refills of opioids or benzodiazepines, people who state that they have lost either their prescription or have dumped their opioids by accident in the toilet. If you notice that they keep having multiple non-coordinated site visits, so like to emergency rooms, urgent cares, those kinds of things. Any arrests or convictions related to opioid abuse, and then a history of chemical abuse or dependence. So are ORS needed for minors? And the answer is yes. We should be doing it prior to prescribing and annually or more frequently if you see those red flags. A question that I also get a lot is, can we do an ORS report on their parents? And you can't, because the parents are not the patient. You can only run ORS reports on your own patient. So you can only run it on that patient. And then exemptions from the mandatory check for ORS, similar to the other ones. If they're a hospice patient, terminally ill, prescribed for 7 days or less, if it's treatment for cancer, if it's for while they're in the hospital, and if it's treatment for acute pain. Again, if you have any red flags and for any of these patients, you should still run an ORS report. So just steps to register. I believe that this last year when we all renewed for our nursing license, we had to say that we had the ORS. But just in case you need it, you just go to the ORS website, you create an account. It should take less than 10 minutes. You don't have to anymore have them have to send in a form or do any of that. You just need to have your driver's license number, your professional license number, your DEA, NPI, and then where you work, and that information. How you log in, Again, you just go to that login button. If you work at UH, they actually on the top screen now have ORS where you can press that button and it will take you straight to the ORS account for that specific patient. So it's pretty easy too. So here's what an ORS report looks like. It gives you the information on what prescriptions were prescribed. So what was the drug? How much? Did they have any refills? Who wrote for it? And where was it filled? So you can get all of that information. They also have the risk level, which is also at the top. So the overdose risk score, which is at the top of the screen, at the top of the slides, but also on the top of the ORS report. The higher the number, the more likely you are to overdose from an opioid. The thing that I found really interesting as well is that if you have an overdose risk score that's greater than 450, the state now requires that you also prescribe a Narcan prescription to patients if you ever have a patient that has that high of a score. They also have many educational resources available on the ORS website for patients, which may be helpful to some people. The other thing that I found interesting is that you can go on ORS and you can look at My RX and you fill in your DEA number and it will actually give you information on all of the prescriptions that you have prescribed for, and you can put in what time period you want to do that, so you can just look back and evaluate what your prescribing history has been. And then this is what it will look like. So it will show you, here's the patient and their information, what medication you prescribed, how much you prescribed, and how many refills. So if you just want to evaluate what your prescribing habits are, this is one way of doing that. What we have found in the 2017 ORS annual report is that having ORS and people checking it has definitely decreased the number of shoppers, opioid shoppers that there are. It's decreased the number of opioids that have been prescribed, and it's decreasing the number of opioids that are being abused and with accidental overdose. So using ORS has definitely made a huge difference. With this, you can see that, like I mentioned, that the number of doctor shoppers is definitely going down, and the number of ORS inquiries is going up, and there's definitely a correlation with those two. So as I was looking up all this information when I was originally asked to do a talk similar to this, and I was looking up the opioid epidemic in Ohio and the United States, I was kind of like, all right, I'm just going to stop writing prescriptions because there's obviously an issue. And then I decided that was probably not a good idea because I do think children have pain and we need to treat that. And I'd also have to find another job. So it seemed like a lot of work. So children's pain is often not recognized or under-recognized, and it's definitely a lot of times there's a lot of research out there that says that it's ineffectively managed. So a lot of that has to do with fear of, I'm sure that there is a fear of this opioid epidemic of not wanting to cause children to become addicted to pain medication. There's also the fear of side effects. I've had multiple residents who've said to me that they know that they were giving an opioid at a really low dose, but they didn't want to be responsible for making them to stop breathing or other such side effects. And then there's just sometimes just not an understanding of pain management in children. So there have been numerous studies, and most of these have been done in emergency rooms. It started in the adult emergency room, where they looked at how they did with managing and treating pain and found out that they did a really poor job with it. And then the pediatric emergency rooms decided that they wanted to look into how they treated pain and found out that we did an even worse job than what the adults who were already doing a bad job. So we do a poor job of assessing pediatric patients and treating them. Part of that is probably because we don't always understand the different pain assessment scales that are out there, and that there are pain assessment scales for infants and toddlers and patients who cannot tell us what type of pain they're having or how bad their pain is. And again, under-treating the pain because of the fear of the negative things that can happen with opioid prescribing, the side effects, and also the epidemic that's going on right now. So our recommendations for prescribing from the Pediatric Pain Service, we like to use a multimodal approach. So we're always going to use non-opioids. So there's Tylenol, which a lot of people are kind of like, it's Tylenol, it doesn't do anything. Tylenol can actually decrease your opioid use by about 20%, so it does something. And then an NSAID is said to be a more superior non-opioid analgesic over Tylenol, but again, don't discount Tylenol. Something else that I like to teach is that we all in nursing school and also in medical school are taught that you should alternate in Tylenol and an NSAID. You actually don't have to do that. You can give Tylenol and an NSAID at the same time every 6 hours. It's not like Tylenol or Motrin stops working at 3 or 4 hours. It will continue to work for 6 hours. Tylenol also works somewhere in your CNS and excreted through your liver. And NSAIDs work at the site of your pain and excreted through your kidney. So they both work differently and excreted differently. So they can kind of work together to help minimize pain. It's also nice for patients when they're in the hospital in the middle of the night. I'm not being woken up every 2 or 3 hours to get pain medication. I'm just being woken up once. For outpatients, it's probably safer than the mom who's waking up or the dad who's waking up at 3 a.m. and is like, okay, what did I give at midnight? Because now I haven't gotten any sleep and I can't remember which medication I give. If in this case, if you're giving them together, then you know that you gave Tylenol and an NSAID at midnight and now it's 6 a.m. so you can give them both. You can also do lidocaine, so you can do a lidoderm patch, which can help at the site. You can either use lidoderm patches, put it on for 12 hours and take it off for 12 hours. You can also leave it on for 24 hours, and what we usually recommend is doing that for 3 days. You can also use topical creams. If they're in the hospital, you can use regional anesthesia, so epidurals or blocks. Both of those can help decrease how much opioid the patient is using. And then non-pharmacological management, so distraction, which can be music therapy, art therapy, listening to music, watching TV. You can do hypnosis or meditation, and also just movement and hot and cold packs. So keeping all of those options in mind. And non-pharmacological management would be the distraction that we talked about. You can also do acupuncture, acupressure, massage, aromatherapy, and physical therapy, and psychotherapy are all options. So the World Health Organization pain ladder, the World Health Organization came out with guidelines originally in 1986 and then updated them in 2012. And with those had a pain ladder that said, okay, if you have mild pain, use a non-opioid. So use that NSAID and that Tylenol. If you have moderate pain, then use a strong opioid. Just for moderate pain, use a slower dose of the opioid, and for the severe pain, using a higher dose. So the example I usually give is oxycodone for moderate pain for an adult. I'd give like 2.5 to 5 milligrams. For severe pain, I would do more of 10 milligrams, maybe 5 milligrams, depending on how big they are. But you're giving bigger dose for the severe pain, a smaller dose for the moderate pain. This is just the guidelines that university hospitals came out for opioid prescribing, and they break it down by they're in the emergency room, you're in an urgent care, this patient has chronic pain, it's a hospice patient, or it's post-surgical. And it goes over what are the goals, what's the prescribing limitation, what should you do with ORS, should you check it or not, and then just the steps to take with treating that pain. So what do you do with long-term pain? Stefan Friedrichsdorf is one of the physicians for pain that's one of the gurus of pain management, and what they do with their chronic pain patients is if they have patients who don't have a reason for the pain that they can find, there's no organic reason, then they don't under any circumstance prescribe any opioids to these patients. Now, what they do with these patients is getting them back to their normal lifestyle using physical therapy, exercise, hypnosis, psychological therapy, and massage. So using more of those non-pharmacological management and coping strategies. So patient education. What we use here at Rainbow is we have this opioid safety information sheet that just goes over what are opioids, what medications are considered opioids, what are the side effects, how can I take it, and then there's just also information about you shouldn't take any opioids at higher doses than what you were already prescribed. You need to call your provider if your pain isn't well controlled with that. You also need to put your opioids in a secure and possibly a locked place. You may want to keep a count of how many opioids you have, and then you want to dispose of those. The big thing that we have found with this opioid epidemic is that how the epidemic continues is that people are prescribed opioids, they take them, they then have leftovers, and they keep it in their medicine cabinet. And then their teenager has a friend that comes over, and they go into the bathroom, and then they take those pills, and then they abuse them. So we want to make sure that we aren't keeping those opioid prescriptions sitting around our house for possible later use, because they do have the potential to be abused. On this, it has a website, which I found interesting when you put in your address, and then it shows you all of the drop-off areas that the locations for controlled substances. And so then that will give you a list of all the different places that you can go to dispose of those prescriptions. And then these are the references, and that concludes this talk, and hopefully that was helpful and beneficial information. Thank you.